I'm sorry about that. We loaded the presentation on the PC and it doesn't seem to work, so now I hope that we are good. So, as Galit said, my name is Dorith Shaham. I'm from the Diagnostic Medical Center, and I was very fortunate to start screening for lung cancer in Israel in 1998. This was the year after I came back from New York, where the ILCAP project started. And what I will do in my talk today is describe lung cancer in Israel as opposed to what we heard about the United States, and screening for lung cancer in Israel, which is part of the ILCAP program. I will outline the principles of lung cancer screening and especially the differences between baseline and annual screening, which are very different. And then I would review the process of how we move, as Professor Fishman described before, how we are trying to move from lung cancer screening in a research setting in Israel to clinical practice. So in Israel, relative to the size of the population, the rate of lung cancer is much lower than we heard before. Nevertheless, it is the #1 cancer killer, even in Israel, and in 2012, according to the Statistical Abstract of Israel, we had over 2,100 new cases and more than 1,700 deaths due to lung cancer. If we compare to the United States, we can see we have the rates of the incidence and the mortality for Jewish and Arab men and women separately here. And if we compare Jewish women to men in the United States, it is about 1/3 in incidence and in mortality, and for women it's only 1/4. So also we have to take this into account when we consider screening for lung cancer in Israel. So this we've heard before, that the lower the stage, the better the prognosis. And this is an illustration of the ILCAP, which stands for International Early Lung Cancer Action Program. It started in New York in 1992 in Cornell and NYU. Then there were 10 additional institutions in the New York area. And today we have more than 70 institutions worldwide, and you can see Israel here. We are listed with other countries in Europe. We also have the Far East, North and South America. And we all screen for lung cancer using the same protocol. We have a registry which has all the images and all the other relevant data referring to each and every individual who was screened, and I will show you some of our, I think, very interesting results in later slides. We also look at things other than lung nodules, such as coronary calcifications, emphysema, breast diseases and other things, and we have published more than 200 papers altogether so far. So this I've already said about the ILCAP, and I think that the most important ILCAP paper was published in the New England Journal of Medicine in 2006, and our data in Israel were also part of this paper. We had more than 31,500 asymptomatic people who were screened for lung cancer using low-dose CT between 1993 and 2005, and we found that stage 1 lung cancer was 85% of all the cancers screened, and the projected 10-year survival was 88% overall, and with when surgical resection was performed in 1 month, it was 92. You have to take into account that usually the survival of lung cancer in regular clinical setting is only about something like 12%. So from 12% we go up to 92% with lung cancer screening. This was not enough for many people who wanted to see reduction in mortality, and the NLST results showed that there was also reduction of mortality. The other thing which is really important for me to emphasize, and I think that if you don't understand this, then you have many pitfalls when you do lung cancer screening, is that there is a profound difference between baseline and annual screening. These are totally different animals, and For each individual, there will be only one baseline screening, but multiple up to 24 if we screen until the age of 80, as recommended by the US Preventive Services Task Force. So it is really the annual screening which will determine the ultimate effect of lung cancer screening. When we do lung cancer screening, we have to decide which is the population that is going to be screened with regard to age and smoking history, what will be regarded as screening positive, and what is the workup which is required for screening. We already heard several times about the difference between solid, non-solid, and part-solid lung nodules. And the definitions go by these types of nodules. So in the baseline screening now, according to ILCAP and to other guidelines, a positive result on baseline screening will be any solid or part-solid nodule which is 6 millimeters and above in diameter. And we heard before about a different study, but we also have an ILCAP study which modeled what will happen if we raise the threshold from 5 millimeters to 6, 7, 8, and 9 millimeters. And as you can see, the percentage of positive results is lower the higher the threshold for screening, and this entails reduction in workup. And according to the ILCAP results, if we raise the threshold from 5 millimeters to 6 millimeters, we will have no 0% of delay in cancer workup. So this is the definition for a positive result of screening on baseline. Of course, we take into account that next year we will have the first annual screening. So if anything, if we missed any small nodule, we can catch it in 1 year. For the annual repeat, the definition is different, and I think there are many radiologists in the audience. You all know that it's totally different when you read the CT scan for the first time, or if you have at least one previous CT to compare to, and a finding which may look very worrisome when you look at it for the first time, when you see that it's stable year and year again, then you know that it's not really a very significant finding. So for the annual screening, any newly detected growing non-calcified nodule, of course, which is equal or greater to 3 millimeters, is considered a positive result of screening, and then there are approximately 7%, so about 10% positive findings according to the definition I gave before for annual screening, and about 7% for annual screening. And then what do you do if you have a positive result of screening? You have to do something, and this something is usually a repeat low-dose CT, and you look for growth. If you think it may be infectious, you can give antibiotics and do a short-term follow-up. You can also do a PET-CT or a biopsy for the nodules which are more worrisome. Now I would like to show you some of the results for the ILCAP registry, which shows the profound differences between baseline and annual screening. So one difference is the rate of negative screening studies. So on baseline, it's 56% of the studies which will be negative, but on annual repeat, this number or this rate goes up to 93%. So on annual screening, we will have more negative studies compared to the baseline. And this is to show it in another way. This is baseline in green, annual on the red, and altogether we have more nodules in each size category on the baseline compared to the annual screening. Then another important thing is the number of lung cancers that are diagnosed. So on baseline, what we see is what we are used to, that the larger the nodule is, and here you can see the size categories, less than 6, between 6 and 9, 10 to 14, and 15 and over. And on the baseline screening, the larger the nodule, the more we will see more cancers in this size category. But on the annual study, it's more or less the same, because what determines the size of the nodule is the rate of growth. So if it's very aggressive, it will go to a bigger size. But the rate, the number of cancers in each size category is essentially the same. Now this ratio of 4 to 1, which is the number of cancers on baseline screening compared to the number of cancers on annual screening, gives us the lead time. The lead time is, the definition of lead time is the time between the diagnosis if screened and the diagnosis without screening. So the lead time in lung cancer screening is 4 years. And the more sensitive the test, and lung cancer screening using low-dose CT is a sensitive test, the larger, the longer the lead time will be. Two other biases, one which was referred to in the previous talk, is the length time bias and the overdiagnosis bias. So length time bias refers to detection of slower growing tumors by screening. This is true only for baseline screening. But in annual screening, what we will see is the fast-growing tumors. And overdiagnosis is this extreme case of the length time bias. These are cancers that are so slow that they will not lead to death if they're not treated. As I will show you in the next two slides, this problem is much more prevalent in baseline screening. So in baseline screening, we have 75% of adenocarcinoma. This is if we look at the differences by cell type. And we have 4% of small cell and 10% of squamous cell, and 2% are typical carcinoid. In the annual screening, we have no carcinoid tumors at all. The rate of adenocarcinoma goes down from 75% to 51%, and the rates of small cell and squamous cell carcinoma go from 4 and 10% to 15 and 20%. So this again shows that we diagnose more aggressive tumors in the annual screening compared to the baseline. And this is again exemplified when we look at the results by the type of the nodule. And we know that most of the overdiagnosed lung cancers will be in subsolid nodules. So the rate of subsolid nodules in baseline screening is much higher compared to is about double compared to the annual screening. So this means that we have much less overdiagnosed lung cancers in the annual screening. So I hope that I convince you that the baseline and annual screening are profoundly different, and the difference is in the frequency of negative CT scans, in the prevalence of lung cancers, in the frequency by cell type, and in the frequency by nodule type. And this again shows that looking at the round of screening is very important, and this was not the case in the NLST study, because the purpose of the NLST study was to show whether there was reduction in death as a result of lung cancer screening. And they had only 2 annual rounds, so the relative significance of the baseline round in this study was much higher than in real-life screening. Now the last part of my talk, I see that my time is up, so I will go very quickly, is moving lung cancer from the research to the clinical practice. So following the NLST study, there was a lot of interest, and many societies recommended to do lung cancer screening in a routine way. And here in Israel, we had a position paper by 7 Israel medical societies which are relevant to lung cancer screening: radiology, pulmonology, family physicians, oncology, chest physicians, public health, and pathology. And we recommend to do lung cancer screening in the same population as the NLST study in the lack of better data for that. We also have flow charts which show what we need to do for every nodule that we find. And we, at least, you know, the ILCAP investigators thinks that lung rates is not the best way to categorize, because it doesn't take into account that lung cancer screening is a process. It's not, and as I said before, you can look at a specific nodule. If you look at it on baseline, it may look one thing or another, but then if you look on annual repeat, you may have a different opinion because you know how it is behaving. And I think that the next version of lung rates will take into account the profound difference between baseline and annual studies. And another thing that I would like to just mention quickly, that we did also a cost-effectiveness study in Israel. The results were very different than what we've heard before. And in our study, the base case incremental cost per quality gain was only $1,464. And now we are looking why it is so different than the numbers that they had in the NLST study. And we also submitted in Israel, we don't have Medicare, but we have the health basket that every resident in Israel is entitled to. And we submitted to the health basket committee lung cancer screening last year, and unfortunately it was rejected, but we will try our luck again in the future. Those of us that really believe that lung cancer screening saves lives. So just 1 minute about what we think the future of lung cancer screening. So we hope that it will become routine practice in Israel, but still we are looking into the role of blood, sputum, and breath test in combination probably with low-dose CT screening. We also anticipate scanner changes and software which will help us in reading, in detecting the nodules and characterizing the nodules, and also with recommendations for management. So I thank you for your attention.